Andrew, this acetyl-L-Carnitine bottle promises sharper thinking, calmer nerves, and somehow faster fat burning on the same label. Are those three claims even measuring the same biology, or is the acetyl tag just marketing glue that makes one molecule sound like three products?
Acetyl-L-Carnitine is L-carnitine with an acetyl group attached. Your cells already use carnitine to shuttle long-chain fatty acids in a mitochondria for beta oxidation. The acetyl form is marketed as the more brain-friendly cousin because it can participate in acetyl traffic near neurons, but that biochemical story is still not the same thing as proven cognition, neuropathy relief, or weight loss outcomes in everyday buyers. Marketing language compresses that gap, so we will keep mechanism and outcome in separate buckets. Picture the carnitine palmitoyl transferase system as a mitochondrial gate. CPT-I helps move fatty acyl groups inside, so oxidation can run and make ADP. That physiology is textbook and useful for understanding energy metabolism. What does not automatically follow is that swallowing extra acetyl-L-carnitine will raise whole body fat burning enough to shrink waistlines or improve race times in people who already eat enough carnitine from food.
So if the shuttle is real, why do fitness videos treat acetyl-L-carnitine like a fat-burning switch you can flip with a daily scoop?
Because transport capacity and clinical fat loss sit on different evidence layers. In trained cyclists, for weeks of acetyl-L-carnitine plus alpha-lipoic acid lowered blood lactate after repeated Wingate efforts. Yet maximal aerobic power and anaerobic performance did not beat placebo. A fatigue-related biomarker moved. The performance and body composition outcomes people usually want did not. That is the classic supplement trap. A lab change gets sold as a lifestyle result.
Hold on, is acetyl-L-carnitine at least absorbed better than plain carnitine since people pay a premium for the acetyl form and the brain story?
A 2025 human metabolism study found the opposite for oral exposure. After 1.5 grams, both forms raised plasma levels, but the increase in area under the curve from acetyl-carnitine was about 7.7-fold lower than from carnitine. Clearance jumped, a large share appeared in urine, and the acetyl-carnitine supplement was mostly eliminated as carnitine. The premium capsule is not a free passport into nervous tissue. The same study also estimated that roughly 90% of both supplements were metabolized toward TMAO, with plasma TMAO reaching about 50 micromolar, levels previously associated with adverse vascular risk signals. That is not an argument against carnitine in ordinary food. It is a caution against assuming high-dose pills are biologically quiet just because the parent compound sounds natural and mitochondrion-friendly. For people already stacking multiple gut-metabolized supplements, that metabolite load is part of the risk conversation.
Okay, absorption and fat burn look soft. What about the nerve pain and brain fog promises that dominate search results and clinic waiting room talk?
Those are the loudest consumer questions, and the evidence is uneven. Neuropathy and cognition studies are often small, mixed, or tied to specific deficiency or disease contexts. Separately, American Oncology guidance on chemotherapy-induced peripheral neuropathy still recommends no agent for prevention, and the clearest treatment signal favors duloxetine rather than a carnitine capsule. Symptom hope is real. Guideline-backed therapy is a higher bar.
Then why do fertility and hormone clinics keep mentioning carnitine stacks? Is that a different evidence lane from the gym bottle?
Sometimes, and the stack design matters. In a 6-month randomized PCOS trial, a nutraceutical mix of acetyl-L-carnitine, arginine, and CoQ10 improved metabolic, hormonal, and quality of life measures, while adding metformin produced larger drops in BMI, waist circumference, and androgens. That is a useful disease context signal, yet it does not prove acetyl-L-carnitine alone is a fat loss drug for metabolically healthy shoppers chasing a supplement aisle claim. In human IVF, culture media with acetyl-L-carnitine, alpha-lipoic acid, and N-acetylcysteine raised fertilization rates, especially after ICSI, and yielded more usable blastocysts per patient. Clinical pregnancy from fresh single blastocyst transfer still did not improve versus control media. That is laboratory embryology with a mixed clinical endpoint, not a consumer claim that a daily capsule will sharpen memory or melt fat. There is also a narrower sexual medicine lane. A network meta-analysis found propionyl L-carnitine plus acetyl-L-carnitine with sildenafil ranked highly for erectile function in organic erectile dysfunction, while many nutraceuticals alone looked weak. Again, that is adjunctive pharmacology in a diagnosed condition, not proof that acetyl-L-carnitine is a general vitality or fat burn tonic. If erectile dysfunction is the actual problem, proven PDE5 inhibitors remain the backbone. Carnitine mixes are secondary at best.
If someone still wants to try a capsule after hearing all that, who should pause and call a clinician first? Seizure history, thyroid disease, anticoagulants, pregnancy, or planned surgery?
Size practical rule still applies. The amount of evidence varies widely across supplements. Store products can differ from study products, and interactions with medications or perioperative timing are real concerns. Gastrointestinal upset is the common complaint. Carnitine forms have seizure cautions in susceptible people, so neurologic history, thyroid status, anticoagulant use, and pregnancy belong in the decision, not in a bottle FAQ.
How would I know it is helping versus expensive placebo? What should I actually track for 4 to 8 weeks before I decide to continue or quit?
Pick one primary outcome tied to your baseline problem. For neuropathy discomfort, track a pain or numbness score and sleep disruption, not bathroom scale weight. For training, watch time trial or interval watts. Remembering lactate can fall without better performance. For PCOS or metabolic care, judge waist change and clinician-ordered labs inside a full plan. If the only durable change is a receipt, the experiment failed cleanly. Keep dose humility. Meat and dairy carnitine is food exposure. Gram-level capsules are concentrated dosing with different absorption and metabolite burdens. Combination powders hide which ingredient, if any, move the needle. Pregnancy, active cancer therapy decisions, anticoagulants, seizure disorders, and upcoming procedures are stop-and-ask boundaries, not optional fine print you can skim later. So the disciplined read is this. Acetyl-L-carnitine rides a real fatty acid transport story. Oral bioavailability is limited compared with carnitine. TMAO production can be substantial at supplement doses, and recent performance trials do not support fat burn or ergogenic marketing. The more honest conversations are disease context stacks under medical follow-up, not one universal nerve-brain fat pill from a thumbnail. Use the molecule when a clinician has a specific context. Ignore the thumbnail that promises nerves, brain, and burn together.